Welcome to Robert Wood Johnson University Hospital Somerset's Health Talk. I'm Dr. Douglas Oshinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Heart disease is the leading cause of death among men and women, linked to 1 out of every 3 deaths. It claims more lives than all forms of cancer combined. On today's show, we will talk about how to keep our hearts healthy, signs and symptoms of heart disease, and treatment options. Joining us today is our special guest, Dr. Ankur Sethi, a cardiologist with RWJ Physician Enterprises, CardioMD. Welcome to the show.
Thank you.
Thank you for being here. First is give us a little background about yourself, education, family.
Sure. I'm a board certified in cardiovascular medicine, echocardiography, nuclear cardiology, and interventional cardiology, and I have special interest in endovascular and percutaneous heart valve interventions. Family-wise, I have 2 young kids, 6 and 3, 2 boys. I'm married to a pediatric oncologist, and here in New Jersey to fix some broken hearts.
Okay, well, hopefully not too many broken hearts. Thank you for being here, and it sounds like a lot of good education and a good someone who's very experienced in interventional cardiology, which at this point is becoming more and more commonplace. So let's begin with an overview of what the heart is, since most people know they have a heart, they don't even know what it's composed of, and why is it such an important component in our body?
Sure. The simplest way to think about heart is it's a pump, which needs to pump every time for you to be alive, and it's made up of different parts, different moving parts. It has a muscle, what we call myocardium. It has valves which control the flow of blood backward and forward. It has its own kind of electrical wiring, which kind of synchronize which part beats at what time. And more importantly, it has arteries, which is essential to supply blood to it. So problems with any of these small pieces can cause heart issues. The most common, what we'll think about a heart attack is when you have blockages in the heart arteries. Then you can get a heart attack, which can cause weak heart muscle and things like that. If you have problems with electricity of the heart, you can get into trouble that your heart doesn't beat as it's supposed to, then you may require a pacemaker. If you have problems with the valves opening or leaking too much, then you can get short of breath because the blood is not going the way it's supposed to be. So it's complicated structure with multiple moving parts, and as I said, problems with any one of these parts can lead you to have symptoms of poor exercise tolerance, shortness of breath, chest pain, and so forth.
So let's start again with the beginning. We've got the heart, which is composed of both muscle, structure, electrical activity. The blood basically is coming into the right side from the rest of the body, which
Correct.
It's deoxygenated blood. The right side of the heart is pumping the blood up into the lungs, getting oxygenation from the lungs coming back down to the left side of the heart. The left side of the heart, being more muscular, is pumping it out to the rest of the body. The heart itself is alive, so it has to itself be supplied by blood itself. Those are the arteries that we were talking about.
Exactly.
And at the same time, since it is a pump, it needs to pump efficiently. So we have an electrical system going in the heart, starting in the top of the heart, moving down to the bottom, that we need to get through correctly so that it pumps the right amount of blood and at the right amount of time.
Exactly.
So the role of what are things that a person can do to improve their heart health?
That's a good question. So for the most part, as the most common cause of heart-related problems in the United States is actually coronary artery disease, or what we call atherosclerotic coronary artery disease. That is plaque buildup inside the coronary arteries, which leads to the problems like angina, heart attacks, and eventually weak heart, right? So when we talk about what we can do to reduce the risk of heart events, we think of doing something to reduce our risk of atherosclerotic coronary artery disease. So it starts from lifestyle, diet, exercise, and what we call premortal prevention. Then it comes to primary prevention, which is avoiding smoking, moderation in alcohol. then exercise, how much you have to exercise every day to keep your heart healthy. And then if there are certain risk factors like high blood pressure and diabetes, unfortunately, some of us just have it, and how important it is to control those risk factors so you can avoid their complications. And most important of it is coronary artery disease, or for that matter, other atherosclerotic disease in the rest of the body.
So again, if we want to avoid having to end up in a cardiologist's office going through all of this, we want to be as active as possible.
Absolutely. So current recommendations by American College of Cardiology is that adult who's older than 40 should exercise at least 150 minutes a week, a moderate exercise, or 75 minutes a week of what we call strenuous exercise. When I say strenuous exercise, this means playing tennis. When I say moderate exercise, this means brisk walking at least, or slow biking. For 150 minutes a week is at least recommendations to keep you fit, because about 50% of Americans don't actually do even this minimum recommendation of exercise. And doing this recommendation exercise, we know from evidence-based literature, reduces your risk of events in future.
So again, it's not even that much exercise as you're describing. 150 minutes over a week is basically talking about 25 minutes a day.
Exactly.
Of brisk walking, slow bicycle riding, or if you're someone who uses a treadmill, you don't even need it that way.
Exactly. You can do a strenuous exercise faster and for 75 minutes. But as I said, 50% of adult Americans don't even do that.
Which is, again, something we need to keep on addressing and keep on getting out there. It's the low cholesterol, low fat diet. Yes, of course, you're allowed to go to a restaurant periodically and enjoy yourself. But at the same time, 90% of the time when you're home, it's the low cholesterol, low fat diet.
Yeah, so I think the basic key point which we see in literature over and over again is to avoid processed food. And when I say processed food, this is purified sugar, processed meat, red meat. These are the things you need to avoid. High carb, high fructose carbohydrate diets, or what you are looking for is complex or whole grains, a diet which is rich in fruits and vegetables, a diet which is rich in lean meat. Fish is a preferred lean meat, or even some white meat. Tend to avoid processed red meat. A Mediterranean-based diet, which is mostly home cooked and not ordered or being eaten from processed cans, I believe. I think that would reduce the risk of events.
Our terrible American diet.
It's easy, but
Again,
I think
studies have shown that the vegetarian diet is a safer, less cardiac, and much more cardioprotective, and even a fish diet. If you want to add fish on, it's not as protective as a vegetarian, but it's almost as protective.
Yeah, I think you're absolutely right. I think the largest study came out of, published a few years ago, which actually have shown reduction in mortality and cardiovascular events, is Mediterranean-based diet, which is rich in nuts and olive oil, which gives you omega, and fish-based diet. You're absolutely right.
And then, of course, it's family history, which unfortunately we can't do much about. It's also making sure that if you do have high blood pressure, that it is well controlled.
Yeah. It's interesting you bring up genetics or family history, because when I see my patients, and it's old teaching and it's been doing it for some time, people ask me what they can do. There are some modifiable and non-modifiable risk factors, right? When we talk about family history, we used to, and for most part, we still think of as a non-modifiable risk factor. This is who you are. You can't really change it. You can only modify some things which you get after you are, right? But now there is some interesting developments in field of epigenetics, which kind of ties in how your genetics interacts with your environment, and how that kind of ties into development of future events. And then some of it actually gets inherited, those epigenetics. Epigenetics deals with proteins, which kind of controls manifestation of your genetic material, which ties into your environment and stress. So I think there's some evidence that somehow, even if you have genes, you can modify their manifestations by controlling the external agents, which is very interesting.
That is very interesting. Another big modifiable risk factor is smoking.
Absolutely. I think I cannot stress enough. I think smoking for me is the single most important cardiovascular and peripheral vascular disease risk factor. the odds of developing coronary artery disease and peripheral artery disease goes up to 20 times if you're a smoker versus a person of same age and gender and exactly same risk factors who is a non-smoker. And once you stop smoking, because I see this all the time, based on my specialty, I'll see a lot of patients who have already have the disease. And once you stop smoking, it takes about 5 to 10 years of not smoking for your risk of cardiovascular disease to match someone who's the same age and risk factors. And it takes about 20 years for the peripheral risk to go down. So I think the most important thing you can do to prevent cardiovascular risk is to not smoke. And if you are a smoker, and to quit. I cannot stress that enough. You're absolutely right.
And nowadays we hear all about vaping also.
Yes. Well, vaping is the new kid on the block. We still don't know enough about it. I think it's not completely safe alternative, although there are studies to support and not. I think at this point, I don't think it's a safe alternative for you to quit smoking. There are other evidence-based medications available which can help you quit smoking if you're trying to do that, rather than using vaping, I think. And there's some literature coming that vaping can somehow affect the lung function, and there are some cases of severe lung disorders following vaping. So I would stress that it's not a benign alternative to smoking, if that's what most people think.
Right, we don't understand enough about the long term of vaping, that it probably is not the best alternative to smoking itself. It's better to use the patch if necessary, better to use smoke enders if necessary, better to use the nasal spray if necessary, better to use the gum if necessary, doing that, or cold turkey and just explaining to your family around you that for 3 or 4 weeks you are not going to be a very nice person, that you need as much help as possible, but if you can give up the cigarettes in 5 to 10 years, your heart will be almost as if you hadn't smoked. And in 20 years, the peripheral vascular components in your body will probably be much more normal also.
Exactly.
Now, being that you are an interventional cardiologist and do stuff with the peripheral vascular, you want to explain to people what the peripheral vascular is and what the peripheral vascular disease is and what you could possibly do about it.
Oh, absolutely. Traditionally, when we think about blockages, most people think about blockages in the coronary arteries. Coronary arteries are moderate-sized arteries of the body, which are kind of a moderate component of collagen and elastin. But you have to also think that there are several other arterial beds in our body, starting from neck arteries, the carotids, the renal arteries, which goes to the kidneys, the leg arteries, and upper limb arteries. All these arteries are prone to plaque buildup in somebody who has risk factors. And these plaque buildups can have different manifestations. A plaque buildup in the carotid arteries can lead to stroke. A plaque buildup in renal arteries can lead to what we call renovascular hypertension. A plaque buildup in the leg arteries can cause claudication, which I want you to think of as the muscle angina. It's something like when you walk, you feel tired and fatigued in your thigh or calf based on which level of the artery is blocked. All of this comes under this umbrella term of peripheral artery disease. So first things are first. One thing goes without saying, that prevention is better than cure. And all of what we talk about for prevention of coronary artery disease is actually applicable for peripheral artery disease. They are so intertwined that almost 60% of people with coronary artery disease would have peripheral artery disease, and almost 40% of people with peripheral artery disease would have coronary artery disease, because their risk factors are same, basically. When it comes to severe blockages, there are interventional options available to treat each vascular bed based on the indication and the disease process.
So at Robert Wood Johnson University Hospital, Somerset, what are those type of interventions or treatments that we can do for the peripheral vascular beds?
Sure. So I think the first step starts off is with the diagnosis. And then, as I said, because it involves so much territory or different vascular bed, you can have different manifestations. For that matter, you can have a TIA or a stroke as a manifestation of carotid artery stenosis. And you can have muscle angina as a manifestation of bad blockages in the leg arteries. Some people who are a little less fortunate, they get picked up later on when they have significant ulceration or gangrene of the toes, for that matter, as a manifestation of severe advanced peripheral artery disease. So we usually start with non-invasive testing in most people, which involves ultrasound or pulse volume recording, which actually measures the pressure or the blood flow at different levels in the legs and see if there is any decrease or increase in blood flow to the arteries. Following which, we can proceed with something called an angiogram, which is similar to coronary angiogram, that we put a catheter in a groin artery and inject dye to see which level is blocked. And based on our findings, we can provide a totally percutaneous solution based on balloons, atherectomy, and stents to improve flow to the vessel and sometimes actually save limbs, because limb saves are actually life saves.
So again, what we're talking about is the same type of risk factors that we have for the heart are the same risk factors for the rest of the peripheral vascular areas of the body. The problem being is that the ones in the legs are much smaller than the ones in the heart. And so it's hard to get to, and we haven't been able to up until recently. So right now what we can do is we can do ultrasounds of the carotids, ultrasounds of the legs, which can be done either at your office or at other facilities.
Mm-hmm. It's very easily available in most offices, actually.
But again, it would be best at a place where they understand the results.
Yes.
And it's better done at a cardiologist's office such as yours, because then you know what to do with the result. Mm-hmm. And then based on those results, you can then go further testing, and then possibility, as you had described, first of doing an angiogram, where basically you're putting a type of catheter into the vein or artery, injecting dye, so you can actually see the anatomy of what's going on.
Exactly.
And then what's nice now is you can percutaneously, meaning just under the skin, go in there and fix things before we run into a problem.
Yes, yes. And that's exactly right. And a lot of times we can, as I said, when we bring you to the catheterization or peripheral suite, with the intention when we are taking pictures that most of the time we will able to intervene and fix the problem at the same time. Because with the ultrasound, we have decent idea what the level of blockage is, what we sometimes underestimate is the extent of it. But almost 99.9% of the time, once we take you for a diagnostic angiogram, we are able to open the arteries to improve circulation to the foot at the same time.
So the good news is that at the same time that you're getting the diagnosis, you can treat it at the same time. Exactly. Also, so the person doesn't have to have pictures done, wait for them to be developed, come back another time to have the same procedure done to have it refixed.
Exactly. And that helps because as you know, and the contrast we inject is something which you need to worry about, because a lot of these people are older, they have kidney issues, and a lot of times kidney beds are involved, so we can really restrict the amount of contrast we have to use by taking pictures and doing the intervention at the same time, rather than keep loading those kidneys with contrast with separate procedures.
Well, it's not that it's a problem, it's that we have to think about that, because it can possibly cause problems with people who've had previous kidney disease. And since this person probably has atherosclerotic heart disease, both in their heart, possibly in their carotids, and possibly in their kidneys, we always have to be concerned about their kidneys if we do any type of intervention, which includes some type of contrast. At the same time, we do procedures and do things beforehand and afterwards to hopefully prevent any complications from this. And more importantly, is that if we can reestablish a circulation in legs, limbs that were not circulating, we may be able to prevent the complications down the road.
You're absolutely right. So the goal is to do all the things which will reduce the risk of any adverse event, and reducing the contrast dose is just one piece. keeping them hydrated, giving them enough post-procedure fluid, and optimizing their medications beforehand all goes hand in hand to reduce the risk of any post-procedure kidney issues, any post-procedure vascular issues, and things like that.
Which again, all important, because when I was an intern resident at a VA hospital, and I used to see the veterans walking in the hallway, and that after they moved, they would have to stop and rub their legs in order to get the circulation going, and what we called claudication, knowing that they had poor circulation in their legs, and down the road we may not be able to do anything other than having to amputate. It's nice that we now have an alternative, especially for anyone who's a veteran, anyone who's has had previous disease, that we can actually save things that we never were able to save before.
Absolutely, absolutely. And we can definitely save many of the limbs. We can reduce the extent of amputation by revascularizing as much as we can. But at the same point, all of what we talk about in primary prevention goes hand in hand after intervention, because I've seen people who after intervention continues to smoke or continues to have elevated risk factors. They tend to do poorly and higher risk of amputation even after revascularization.
Now, being that you are an interventional cardiologist, you also have role in people's heart valves, don't you?
Yes. I have some special interest in heart valve intervention. I spent some time training for these interventions. The most common one nowadays, probably everybody has heard about, is TAVR, or aortic stenosis. The second one, which is commonly used, is called mitral clip, which is for mitral regurgitation. And aortic stenosis and mitral regurgitation by far are the most common valve disorder in the United States.
Now, the aortic valve, for people who don't know, is the large valve that leads from the left heart up to the body.
Yes, so aortic valve is an essential valve which is between the conduit called aorta and the left ventricle, which is actually the actual pump of your body. Every time your heart beats, that valve opens wide. And as you can imagine, your heart roughly beats about 60 to 70 times a minute. And if you're 80, 90 years old, it has been millions of times since then. And there are a few percentage of us which will have enough calcium deposit on the valve that in their 70s and 80s, this valve tend to not open very widely. The opening is restricted. And as you can imagine, every time you exercise, you need more blood flow to your muscles for you to be able to exercise. And that requires your heart to pump a little faster, a little more efficiently, and your valve to open a little wide for your left ventricle to deliver that blood. In somebody with severe aortic stenosis, that opening is restricted. So every time they would exercise, or from exercise, I mean every time they will do any kind of physical activity, they may feel short of breath. They may feel dizzy or lightheaded because of not getting enough blood to their head. And sometimes they may feel angina. These are the common three symptoms of severe aortic stenosis.
And up until this point, basically, we would have to open up the heart to replace the valve.
Yes, so the traditional treatment have been open heart surgery for that, and which requires making an incision, cracking open the sternum, cross-clamping your aorta, taking out the old valve, putting a new valve in, switching you back in, and followed by some amount of recovery in the hospital and the rehab. So that's why the sicker of our patients were not offered this treatment in the past. But since 2011, Medicare approved this new treatment called TAVR, or transcatheter aortic valve replacement. What it entails is that you could potentially place a new valve percutaneously, or at least not opening the chest, inside your old valve, and it starts working right away. For most people who are done percutaneously, this means getting back to where they were, or going back home within a day or two of hospital stay, which I think is a game changer.
And again, what's great is the fact that you can now do this at Robert Wood Johnson Somerset, as well as Robert Wood Johnson New Brunswick.
We do this procedure at Robert Wood Johnson New Brunswick in close collaboration with our cardiothoracic colleagues. And then I think Robert Wood Johnson is one of the highest volume centers in New Jersey, and we have access to all new valve systems, and I think it's a wonderful place to be if you have severe aortic stenosis.
And the fact that, again, it's percutaneous rather than fully opening up the chest. Easier procedure, less side effects, less problematic, and an easier recovery.
Definitely easier recovery. Now it's approved recently for low risk category of patients. Until about few months ago, we were calculating the risk score of every patient to see if they are considered higher intermediate risk for surgery. That's why there will be a better TAVR candidate. But with the recent trials, namely Partner 3 and then Evolute low risk, we know that people even who are considered low risk for surgery do as well, if not better, with TAVR. Certain complications are certainly less common with TAVR, which include kidney injuries, atrial fibrillation. Certain things are still a little bit more common, which means requiring a pacemaker, and it may be a function of what kind of valve you use rather than TAVR versus surgical valve. But all in all, I think TAVR is a very promising procedure for people with severe aortic stenosis.
Thank you. Thank you very much. And I wish we had more time to go over even more stuff with you. Maybe we'll have you back so you can give us more education.
Absolutely. It will be a pleasure.
This concludes today's episode of Robert Wood Johnson University Hospital Somerset's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 888-724-7123. Download the RWJBarnabas Health Connect app to schedule doctor appointments online and manage your health records right from your phone or tablet. For more information about Robert Wood Johnson University Hospital Somerset, please visit our website at www.rwjbh.org/Somerset. Thank you, Dr. Sethi, for being here, and thank you for joining Robert Wood Johnson Hospital and doing everything that you do.
Pleasure.